Welcome to this session on classic signs on chest radiographs, a primer for residents. I'm AI Chavelle, and this session is brought to you by Dr. Yu-Dong Chen. This session is based on content from the January 2025 issue of Radiographics. Over the course of this presentation, we will carefully examine key radiographic signs, understanding what they represent, why they matter, and how they guide clinical decision-making in thoracic imaging. Here is the table of contents for today's presentation. We will begin with an introduction, setting the stage for why classic chest radiographic signs remain important in modern clinical practice. Next, we will outline the learning objectives, focusing on recognition, mechanisms, and clinical application of these signs. We will then briefly review chest radiograph anatomy and discuss the chest radiograph technique, emphasizing differences between anteroposterior and posterior anterior views. Following that, we will address potential pitfalls and challenges, highlighting technical limitations, human factors, and anatomic mimics that can complicate interpretation. The major portion of our session will be dedicated to classic radiographic signs. These include hallmark findings such as the air bronchogram sign, the bat wing pattern, the air crescent, the monad sign, the water lily sign, the bulging fissure sign, and many others, extending through the thymic wave sign. Each sign will be reviewed with its definition, underlying mechanism, and differential diagnosis. Finally, we will close with a summary, distilling the key teaching points, and then provide a list of suggested readings for deeper study and reinforcement. This structured approach will allow us to move from foundational principles to advanced pattern recognition, strengthening our skills in chest radiograph interpretation. Classic chest radiograph signs are distinctive visual patterns that help radiologists diagnose, characterize, and localize thoracic disease. These signs have been documented through decades of clinical experience, and they remain essential teaching elements in radiology and pulmonary medicine. Recognizing and correctly reporting these findings is not just academic. Timely identification of these patterns can be critical for patient management. Our objectives today are threefold. First, we will review and describe the classic signs seen on chest radiographs. Second, we will explore the underlying mechanisms and etiologies that give rise to these signs. And finally, we will highlight the clinical significance of each sign, with attention to differential diagnoses that should be considered in daily practice. Before we explore the signs themselves, it is essential to ground ourselves in chest anatomy as it appears on radiographs. A solid grasp of the relationship between the lungs, mediastinum, diaphragm, and chest wall structures provides the foundation for identifying subtle yet clinically important radiographic patterns. Image acquisition matters. The technique used directly influences what we see and how we interpret it. In the anteroposterior, or portable view, the X-ray beam enters from the front and exits posteriorly, with the detector placed behind the patient. This is usually performed with the patient supine or semi-erect. While convenient, it is more prone to artifacts, leads to magnification of the heart, and often results in lower lung volumes. Obtaining a lateral view is difficult, but this method avoids the need for patient transport. By contrast, the posterior anterior, or standard view, is performed with the patient standing erect. The beam travels from back to front, with the detector in front of the chest. This produces superior image quality, fewer artifacts, and usually allows an accompanying lateral film. The trade-off, however, is that patient transport is required. Always remember, understanding whether an image is AP or PA is crucial for accurate interpretation. Interpreting chest radiographs is not without challenges. There are technical factors. Poor image quality from inadequate exposure, incorrect positioning, or patient motion can obscure key findings. Suboptimal positioning may also distort anatomy, while the two-dimensional nature of radiographs leads to superimposed structures that complicate interpretation. Small lesions may remain hidden behind the heart, diaphragm, or bony thorax. There are also common pitfalls. Shadows from nipples, skin folds, or external objects can mimic pathology. Failing to compare with prior studies risks missing disease progression. An incomplete or misleading clinical history may bias interpretation. Human factors also play a role. Inexperience, fatigue, and cognitive bias, such as anchoring to a presumed diagnosis, can all reduce accuracy. Finally, anatomic variations and mimics deserve attention. Accessory fissures, overlapping ribs and clavicles, or benign vascular structures can resemble pathology. A skilled radiologist must always distinguish normal variants from disease. The air bronchogram sign refers to visible air-filled bronchi coursing through a background of alveolar opacity. It indicates that the bronchi remain patent, while the surrounding alveoli are filled or collapsed. Causes include absorption of air as an atelectasis, or replacement of alveolar air by pus, blood, fluid, or tumor. A classic case: a patient with bronchopneumonia shows patchy opacities in the lower lungs. Linear tubular lucencies represent the air-filled bronchi outlined against surrounding consolidation, hallmarks of the air bronchogram sign. Batwing opacities, also called the butterfly shadow, describe bilateral, symmetric, central lung opacities that spare the periphery. This pattern reflects central alveolar involvement with relative preservation of peripheral clearance. Important differential diagnoses include pulmonary edema, most commonly cardiogenic; diffuse pulmonary hemorrhage, pneumocystis pneumonia, viral or inhalational injury, and pulmonary alveolar proteinosis, for example. In acute pulmonary edema from coronary ischemia, the parahilar opacities radiate outward like wings, an unmistakable bat wing pattern. The air crescent sign is a crescent-shaped pocket of air between a lung cavity wall and a central mass. It typically appears during recovery from invasive pulmonary aspergillosis, when retracted infarcted tissue separates from viable lung, creating the crescent. This sign is especially important in immunocompromised patients. It often marks transition toward recovery after neutrophil counts rebound. On imaging, a mass may initially appear solid, but with therapy, a new crescent of air develops at the cavity margin, classic for the air crescent sign. The monad sign describes gas encircling a freely mobile intracavitary mass, most often an aspergilloma within a pre-existing cavity. Unlike the air crescent sign of infarction, the monad sign reflects colonization of an old cavity by a fungus ball. Differential considerations include fungal balls such as aspergillomas, hemorrhage or blood clot within a cavity, intracavitary tumors, or cavitating pneumonias or infected bulli. A representative case: in a patient with prior tuberculosis and sarcoidosis, bilateral apical cavities are present. CD confirms a mobile fungal ball, outlined by air, producing the monad sign. The water lily sign is highly characteristic of a ruptured hydatid cyst. It occurs when the endocyst, or inner membrane of the cyst, detaches from the outer paracyst and collapses. The floating membrane inside the residual cavity resembles a water lily resting on water. Hydatid disease is caused by a Echinococcus tapeworm infection. When rupture occurs, the detached endocyst becomes visible within the cyst fluid, creating this striking radiographic feature. Differential diagnoses include ruptured hydatid cysts, cavitating lung cancers, and lung abscesses. In practice, a retrocardiac mass may first appear solid. Later, the development of an air fluid level with floating membranes creates the classic water lily appearance. The bulging fissure sign is produced when an infected or infiltrated lobe becomes so expanded that it displaces adjacent fissures. Historically, it was considered pathognomonic for Klebsiella pneumoniae infection, particularly in the right upper lobe. However, it can also result from other bacterial pneumonias, lung adenocarcinoma, pulmonary lymphoma, lung abscesses, or even pulmonary hemorrhage. On chest radiographs, the affected lobe appears swollen, with its fissural margins pushed outward, producing the so-called bulging fissure. The cervicothoracic sign helps localize upper mediastinal masses. A positive cervicothoracic sign means that the inferior border of the lesion is visible below the clavicle, but its superior margin is obscured above it. This suggests the mass lies in the anterior mediastinum, where soft tissues of the neck silhouette its upper border. Typical differential diagnoses include substernal goiter, mediastinal lymphoma, and thymic tumors. For example, a mediastinal goiter may appear as a dense upper mediastinal shadow whose inferior margin is distinct, while its upper border fades into cervical soft tissue. In contrast, a negative cervicothoracic sign indicates that the superior border of a mediastinal mass remains visible above the clavicles. This implies that the lesion resides in the posterior mediastinum, where it lies against air-filled lung and is not silhouetted by cervical soft tissue. Key differential diagnoses include neurogenic tumors, vertebral body neoplasms, paraspinal abscesses or hematomas, and thoracic meningocele. For instance, a paravertebral neurofibroma may create a smoothly marginated mass that remains visible well above the clavicles, illustrating the negative cervicothoracic sign. The silhouette sign is based on a simple principle. Structures of the same radiographic density that come into direct contact will obscure each other's borders. Thus, when a normally distinct border is lost, it indicates pathology at that anatomic level. For example, loss of the right heart border suggests right middle lobe disease. Loss of the right hemidiaphragm indicates right lower lobe involvement, and obscuration of the left heart margin often points to lingular pathology. Clinically, this sign helps localize pneumonia, atelectasis, masses, or effusions to specific lung zones. It is one of the most fundamental localization tools in chest radiography. The abdominothoracic sign is a variation of the silhouette sign, and it helps determine whether a mass projects from the thorax or the abdomen on a frontal chest radiograph. Here's the principle. The posterior costophrenic sulcus sits lower than the anterior. If the caudal margin of a lesion is visible below the dome of the diaphragm, the lesion must be posterior and entirely intrathoracic. This is called a negative abdominothoracic sign. If, however, the caudal border of the opacity is obscured by abdominal soft tissues, the sign is considered positive, indicating extension or origin from the abdomen. In practice, a hiatal hernia produces a positive sign, while a paravertebral lymphoma extending into the chest can yield a negative one. This sign is particularly helpful in localizing retrocardiac masses. The spine sign, sometimes called the Moore Black sign, is assessed on lateral chest radiographs. Normally, the thoracic spine becomes progressively darker from top to bottom because of the increasing volume of aerated lung. If, instead, the lower thoracic spine appears more opaque, it suggests pathology in that region, such as consolidation, atelectasis, or tumor. For example, a patient may have a normal-appearing frontal radiograph, but the lateral film reveals abnormal density over the lower spine. CT may confirm a left lower lobe mass. This illustrates how the spine sign helps uncover subtle posterior lung disease that might otherwise be missed. The Comet tail sign is characterized by a curving opacity extending from a subpleural mass toward the hilum, resembling the tail of a comet. This appearance is caused by distortion of bronchi and vessels being dragged into an area of round atelectasis, a folded lung segment that mimics a mass. Round atelectasis often arises in the setting of chronic pleural disease, such as asbestos-related effusions or pleural thickening. Radiographs reveal a pleural-based opacity with sweeping curvilinear bands, while CT confirms a rounded atelectatic lobe with bronchovascular structures curving toward the hilum. The Comet tail sign is highly characteristic and prevents misdiagnosing round atelectasis as malignancy. The continuous diaphragm sign refers to visualization of the central portion of the diaphragm, which is usually obscured by the heart. It occurs when air collects in the mediastinum, pericardium, or peritoneum, outlining the diaphragm across its midline and creating the illusion of an unbroken, continuous line. This sign is a valuable clue to pneumomediastinum, pneumopericardium, or pneumoperitoneum. For example, in Boerhaave syndrome, esophageal rupture after forceful vomiting, mediastinal air outlines the diaphragm, making the normally hidden central tendon sharply visible. The deep sulcus sign is an important indicator of pneumothorax in supine patients. Instead of seeing air at the lung apex, as in upright films, pleural air in the supine position collects anteriorly and basally, pushing the diaphragmatic pleura downward. This creates an abnormally deep, sharp costophrenic angle, which is highly suspicious for pneumothorax. A trauma patient lying supine, for example, may show a deceptively normal-appearing chest film, except for a strikingly deepened right costophrenic recess. CT will confirm pleural air, validating the deep sulcus sign. Always remember, in critically ill or trauma patients, this subtle sign may be the only radiographic clue to pneumothorax. The double diaphragm sign appears when two parallel diaphragmatic contours are visible above the lung bases. It results from pneumothorax, where both the posterior and anterior pleural reflections of the diaphragm become outlined by intrapleural air. On a frontal chest radiograph, the normal dome of the diaphragm is seen, and just above it, a second curvilinear contour appears. This represents the anterior portion of the diaphragm, separated by air from the posterior dome. In practice, recognizing this sign is critical. It distinguishes pneumothorax from simple subdiaphragmatic or basal lung findings, ensuring that urgent management is not delayed. The ginkgo leaf sign is a striking manifestation of severe subcutaneous emphysema. Here, air dissects along the fibers of the pectoralis major muscle, producing a streaky or branching pattern that resembles the veins of a ginkgo biloba leaf. This sign is typically seen in extensive subcutaneous emphysema, often secondary to trauma, pneumothorax, or pneumomediastinum. On radiographs, the chest wall appears laced with branching lucencies, perfectly mimicking the venation of a ginkgo leaf, a helpful visual clue for diagnosis. The ring around the artery sign is observed when mediastinal air outlines the right pulmonary artery, creating a crescentic halo of lucency. Originally described on lateral chest radiographs, this sign is a classic marker of pneumomediastinum. The accumulation of mediastinal air forms a radiolucent semicircle encasing the artery, which is rarely confused with other conditions. Recognizing this sign not only supports the diagnosis of pneumomediastinum, but also helps distinguish it from pneumopericardium, where air is confined to the pericardial sac. The Naclerio V sign is another important indicator of pneumomediastinum, often related to esophageal perforation. On frontal radiographs, mediastinal air creates a V-shaped lucency. One limb outlines the lateral border of the lower mediastinum. The other limb traces air between the medial left hemidiaphragm and the descending thoracic aorta. Because esophageal rupture frequently produces this sign, its recognition should prompt urgent clinical correlation and further investigation. Missing the Naclerio V sign could delay life-saving intervention in a critically ill patient. The double density sign, also called the double right heart border, indicates left atrial enlargement. Normally, the right cardiac border is a single smooth contour. When the left atrium enlarges posteriorly, its silhouette projects into the retrocardiac space, creating a second curvilinear shadow superimposed upon the right heart margin. On chest radiographs, this double contour should raise suspicion not only for left atrial enlargement, but also for other causes such as low-ascending aortic aneurysm, hiatal hernia, or mediastinal masses. In clinical practice, severe mitral stenosis is a classic cause of this sign, and CT can confirm left atrial dilatation. The egg on a string sign is a classic finding in congenital heart disease, most often transposition of the great arteries. On a frontal chest radiograph, the heart appears globular, resembling an egg lying on its side. The mediastinum above the heart is unusually narrow, producing the impression that this large cardiac silhouette is suspended by a thin string. This appearance results from abnormal convexity of the right atrial border combined with left atrial enlargement, while thymic atrophy and hyperinflated lungs accentuate the narrow superior mediastinum. While most strongly associated with transposition, it may also be seen in conditions such as pentalogy of Cantrell. Recognizing this pattern is crucial in neonates and infants presenting with cyanosis. The donut sign is best appreciated on lateral chest radiographs. It occurs when enlarged lymph nodes in the precarinal, subcarinal, and retrocarinal regions encircle the trachea and mainstem bronchi, forming a ring-like opacity that resembles a donut. This sign indicates mediastinal lymphadenopathy, with causes including sarcoidosis, infections such as tuberculosis or histoplasmosis, lymphoma, or metastatic malignancies. When present, the donut sign should prompt careful evaluation of the mediastinum and consideration of systemic disease. The Fleischner sign refers to enlargement of a central pulmonary artery. This finding is often due to a massive pulmonary embolus, causing abrupt arterial dilation with distal tapering, sometimes called the knuckle sign. In chronic settings, pulmonary hypertension or aneurysmal dilatation may also produce the same appearance. On chest radiographs, a disproportionately enlarged interlobar pulmonary artery may be visible. Correlation with CT angiography typically demonstrates intraluminal thrombus and additional emboli in the pulmonary circulation. The Fleischner sign is therefore an important radiographic clue to pulmonary embolism and related vascular disease. The Westermark sign indicates regional allogemia, that is, decreased vascular markings distal to a pulmonary embolism. The sign is produced by dilation of vessels proximal to the clot and collapse or vasoconstriction of vessels beyond it. The result is a sharply demarcated area of reduced perfusion, often described as a focal lucency on chest radiographs. This is a subtle but critical finding. Its presence should always raise suspicion for acute pulmonary embolism. While most often associated with embolism, similar appearances may occur in congenital pulmonary artery hypoplasia or aneurysm. The Hampton hump sign is another hallmark of pulmonary embolism, representing pulmonary infarction. It appears as a triangular or wedge-shaped opacity at the lung periphery, with its apex directed toward the hilum and its base against the pleura. On CT, this corresponds to a wedge-shaped consolidation, usually hemorrhagic infarction. Differential diagnoses include pulmonary infarction from embolism, but also organizing pneumonia or infectious consolidation. In the correct clinical setting, however, the Hampton hump is a strong radiographic indicator of acute pulmonary embolism. The gloved finger sign, also called the finger and glove sign, refers to branching tubular opacities extending outward from the HeLa toward the lung periphery. These represent dilated bronchi that are completely filled with inspissated mucus. Obstruction of the bronchus, whether by inflammation, tumor, or congenital anomaly, leads to secretion retention, mucus plugging, and bronchial dilatation. Important differential diagnoses include allergic bronchopulmonary aspergillosis, congenital bronchial atresia, cystic fibrosis, and airway obstruction from neoplasms or foreign bodies. On chest radiographs, these tubular opacities strikingly resemble gloved fingers reaching into the lung fields. The hilum convergence sign helps distinguish vascular enlargement from hilar masses. If pulmonary vessels can be traced as they converge toward the lateral margin of an abnormal hilar opacity, this indicates an enlarged pulmonary artery. Conversely, if vessels appear to pass around the opacity without converging, the abnormality is more likely to represent lymphadenopathy or a hilar mass. This sign is particularly useful in differentiating pulmonary arterial hypertension or aneurysm from nodal or neoplastic hilar disease. The hilum overlay sign is another localization tool. If hilar vessels are clearly visible coursing through an opacity, the lesion is not within the hilum itself. Instead, it is located anterior or posterior to the hilum. If, however, the opacity obscures the hilar vessels, the lesion is intrahilar. This distinction helps refine the differential between lung consolidation, chest wall masses, or mediastinal lesions versus hilar neoplasm or nodal disease. The holly leaf sign refers to pleural plaques, calcified, irregularly marginated densities along the pleural surfaces that resemble the jagged contour of a holly leaf. These plaques are strongly associated with asbestos exposure and usually involve the parietal pleura of the lower chest, sparing the apices and costophrenic angles. When visceral pleura is involved, it is often in conjunction with parenchymal fibrosis or other asbestos-related lung disease. Recognition of this sign is important, as it is a hallmark of asbestos-related pleural pathology. The incomplete border sign helps differentiate extrapulmonary lesions from intrapulmonary ones. With an extrapulmonary lesion, the inner margin of the opacity, bordering lung, appears sharp and well-defined due to the contrast with adjacent aerated lung. But the outer margin, adjacent to chest wall, appears indistinct because of limited contrast. Intrapulmonary lesions, by contrast, usually show sharp margins all around. Common examples producing the incomplete border sign include rib tumors, intercostal schwannomas, or nipple shadows mistaken for nodules. The juxtaphrenic peak sign, also known as the Caton sign or diaphragmatic tenting, refers to a peaked configuration of the hemidiaphragm. It is most often seen in cases of upper lobe collapse or post-lobectomy volume loss. The peak is created where the lower end of the diaphragm is pulled upward by an inferior accessory fissure, a major fissure, or the inferior pulmonary ligament. Differential considerations include ipsilateral volume loss from lobar collapse, surgical resection, post-infectious scarring, or fibrotic lung disease. On radiographs, the diaphragm appears pointed upward like a tent, a visual cue to reduced ipsilateral lung volume. The meniscus sign is one of the most classic indicators of pleural effusion. On upright chest radiographs, fluid in the pleural space accumulates and curves upward laterally, producing a smooth concave contour that resembles a meniscus. This occurs due to surface tension between pleural fluid and lung tissue. A true meniscus sign strongly suggests pleural effusion, which may be caused by infection, heart failure, malignancy, or inflammatory disease. However, in cases of very large masses or dense atelectasis, the meniscus may be absent. The presence or absence of this sign provides important diagnostic information for pleural-based disease. The Oreo cookie sign is a radiographic indicator of pericardial effusion. On lateral chest radiographs, a central dense band, representing fluid, is bordered by two lucent stripes created by pericardial and epicardial fat. This layered appearance mimics the creamy filling sandwiched between two dark cookies in an Oreo. When present, this sign is highly specific for pericardial effusion and should prompt further correlation with echocardiography or CT. The water bottle sign describes the configuration of the cardiac silhouette when the pericardial sac is distended with fluid. The heart appears enlarged, rounded, and flask-shaped with a broad base tapering upward, resembling a traditional water bottle. This sign is most often due to pericardial effusion, though pericardial malignancy and severe cardiomyopathy can mimic the same silhouette. When newly developed, the water bottle sign is a key diagnostic clue to pericardial effusion and often prompts urgent further evaluation. The scimitar sign is a hallmark of scimitar syndrome, also called congenital lobar syndrome or hypogenetic lung syndrome. It results from anomalous pulmonary venous return from the right lung into the inferior vena cava or portal vein. The anomalous vein creates a curvilinear opacity along the right lower chest wall, resembling a Turkish curved sword or scimitar. This sign is most commonly seen in association with right lung hypoplasia, cardiac dextroposition, and other congenital anomalies. While scimitar syndrome is classic, other mimics include arteriovenous malformations or sequestration. Recognition of the scimitar sign is key to identifying this rare but important congenital abnormality. The Luftsickle sign, literally meaning air sickle in German, is characterized by a crescent-shaped area of air adjacent to the aortic arch. It occurs most often in left upper lobe collapse. In this situation, the superior segment of the left lower lobe becomes hyperexpanded and interposes itself between the mediastinum and the collapsed lobe. This hyperexpanded segment outlines the aortic arch, leaving its contour visible despite the collapse. Differential diagnoses include left upper lobe collapse, right lung herniation, and, less commonly, pneumomediastinum. On radiographs, this air crescent hugging the aorta is a distinctive and reliable clue to upper lobe volume loss. The sail sign and flat waist sign are both associated with left lower lobe collapse. The sail sign refers to a sharply outlined, triangular opacity behind the heart, created by the collapsed lobe projected over the cardiac silhouette. The flat waist sign describes the straightening of the left cardiac margin, particularly the contours of the aortic arch and pulmonary trunk, as the collapsed lobe pulls the heart leftward and upward. Together, these two signs provide powerful radiographic evidence of left lower lobe collapse. The golden S sign, also called the reverse S sign of golden, is seen when a central mass obstructs the right upper lobe bronchus, producing lobar collapse. The collapsed upper lobe creates a concave margin, while the obstructing mass forms a convex bulge. The combined effect is an S-shaped contour along the fissure. This sign is highly suggestive of a central obstructing lesion, most often primary bronchogenic carcinoma, though metastatic disease may also cause it. On chest radiographs, the distinctive reverse S-shaped border should always prompt suspicion for malignancy until proven otherwise. The spinnaker sail sign, sometimes called the angel wing sign, is most often observed in neonates with pneumomediastinum. Here, mediastinal air dissects between the thymus and the heart, lifting the thymic lobes upward and outward like sails filled by the wind. On frontal radiographs, the thymus appears elevated into the mediastinum, while lateral views show loosened mediastinal air surrounding the heart and thymus. Recognition of this sign is important, as it may obviate the need for invasive testing. In severe cases, this may progress to the haystack sign. The haystack sign is a variant of the spinnaker sail sign, and it too is seen in pediatric pneumomediastinum. When mediastinal air accumulates to a high degree, the thymus is displaced and expanded, creating a bulky opacity that resembles a haystack, reminiscent of the haystacks painted by Claude Monet. The haystack sign indicates a high-pressure pneumomediastinum. Prompt recognition is vital, particularly in neonates, to guide further supportive management and avoid misdiagnosis. The thymic notch sign is a normal pediatric finding that helps distinguish the thymus from a mediastinal mass. On frontal radiographs of infants or young children, the upper border of the thymus sometimes shows a small indentation, or notch, where it is indented by adjacent ribs. Recognizing this sign is important because it prevents misinterpreting a normal thymus as a mediastinal tumor. In pediatric imaging, awareness of this sign can spare unnecessary further investigations. In short, the thymic notch sign is a reassuring marker of normal thymic anatomy. The thymic sail sign is another normal radiographic variant in children. It occurs when the thymus, which is relatively large in infants, projects laterally over the lung fields and assumes a triangular configuration. The straight margin of this triangular outline resembles the edge of a sail. The thymic sail sign is typically seen on the right side, and it must be distinguished from the spinnaker sail sign, which indicates pneumomediastinum. When identified, the sail sign confirms a benign thymic contour, avoiding unnecessary alarm. The thymic wave sign is yet another normal thymic appearance seen in neonates and young children. In this case, the thymus displays a wavy contour on frontal radiographs. The undulating margin is created by the impression of adjacent ribs against the soft thymic tissue. The thymic wave sign reassures us that the opacity is physiologic thymus, not pathologic mass. It is a hallmark pediatric radiographic variant, reminding us to recognize normal thymic borders. The stag's antler sign, sometimes called the inverted mustache sign, reflects pulmonary venous redistribution to the upper lobes. It is most often seen in pulmonary venous hypertension or pulmonary edema. The upper lobe veins become prominently distended, radiating upward like the branching antlers of a stag. This pattern alerts the reader to elevated left atrial pressure, pulmonary venous congestion, or arteriovenous malformations. In the setting of heart failure, this sign is a visual cue to hemodynamic compromise. This slide provides a summary table of the classic signs, their definitions, and their key differential diagnoses. For example, the air bronchogram sign highlights air-filled bronchi with an opaque lung, seen in pneumonia or pulmonary edema. Bat wing opacities reflect central distribution of infiltrates, classic for pulmonary edema. The air crescent and monad signs point toward invasive fungal disease or aspergilloma. The silhouette sign helps localize disease by identifying lost anatomic borders. And the meniscus sign is a time-honored marker of pleural effusion. This summary table consolidates the many signs we have reviewed, serving as a quick reference guide for clinical practice. The chest radiograph remains one of the most fundamental diagnostic tools in medicine. It often provides the very first clue to thoracic pathology, guiding further evaluation and management. Classic radiographic signs are more than teaching curiosities. They are essential markers that sharpen diagnostic accuracy in both emergency and routine settings. Even as advanced imaging modalities like CT and MRI expand our capabilities, the knowledge of these traditional signs remains indispensable. By mastering them, radiologists and trainees alike strengthen their ability to deliver precise, timely diagnoses, ultimately improving patient outcomes. Classic signs on chest radiographs will continue to serve as a cornerstone of radiologic education and clinical practice.